The permissive, underfeeding, or standard enteral feeding in the critical adults. Definition. It is measure of the nutritional support the consistent of the administration of nutrients in the digestive system directly. This can be our enteral nutrition. Enteral nutrition by tooth nutritional support is an essential part of the management of the critical. In patients, this technically accurate with importance. When a patient has an inability to ingest food that maintains gastrointestinal function.
Welcome to Metabolism Matters. I'm Jennifer Woolley. Today, we'll be talking about feeding critically ill patients. Feeding critically ill patients isn't easy. This is because acute illnesses can stress a patient's metabolism and make it difficult to anticipate their caloric needs. To emphasize the difficulty in calculating a critically ill patient's caloric needs, let me share this fact. Did you know more than 50% of ICU patients wind up malnourished? When a patient suffers from malnutrition, they can become dependent on the mechanical ventilator. This means they will be in the hospital longer, which increases morbidity and mortality as well as costs. The dietitian's job is to protect patients from malnutrition by providing proper nutrition intervention. And luckily, there are tools to help the dietitian do just this. One tool is predictive equations to estimate energy expenditure. As an example, this is the Harris-Benedict equation. Predictive equations are often used because they are convenient and inexpensive. Unfortunately, they have many drawbacks. There are hundreds of equations. There is lack of consensus about which equations are the best to use, which leads to significant practice variation. And they are only accurate less than 40% of the time. Less than 40%? Let's get another tool, shall we? Let's look at indirect calorimetry. First of all, what is it? Indirect calorimetry uses inspired oxygen consumption and expired carbon dioxide production to accurately calculate energy expenditure. The coolest thing about indirect calorimetry is it's a measurement, not an estimate. It's also objective and accurate because it's tailored to each patient. And it's not just me saying that. According to the Society of Critical Care Medicine and the American Society for Parenteral and Enteral Nutrition 2016 guidelines for the provision and assessment of nutrition support therapy in a critically ill patient, indirect calorimetry should be used to determine energy requirements when available. That means if you've been asked to follow SCCM and ASPEN guidelines, you should be using indirect calorimetry. So the next question people ask is, what are the equipment options for indirect calorimetry? Equipment options include metabolic carts, handheld or tabletop devices, or, and I find this to be the easiest, an indirect calorimetry or airway module built into a mechanical ventilator. Well, that's it for today. I'm Jennifer Woolley for Metabolism Matters. See you next time.
The medical application. Prevents malnutrition and current nutritional problems. Prevents protein self-catabolism, bacterial overgrowth, the bacterial translocation, the loss of the immune defense of the digestive system, and the atrophy of the enterocyte.
In this module, I am going to discuss about the nutrition support into the intensive care unit, which is a very important component of all patients who are admitted to the intensive care unit. We will go case-wise. Let's take a 25-year-old patient who is 180 kilos and he is a motorcycle victim with polytrauma, has a large flared chest, left lung has contusion, there is a left hemothorax, there is a blunt trauma of the abdomen with large bruises over the epigastrium, and has a both fracture of the tibia and the fibula in the right lower extremities. The vitals, as you can see on the slide here, he is in shock with a BP of 70 systolic. He is tachycardic with 145 pulse. The respiratory rate is 42. He is polyconscious, but he is in respiratory distress. And as an intensivist, we have been asked to formulate a nutritional plan for him. So whenever, as an intensivist, the most important part, like we planning the plan of care, we plan about nutrition is very important, along with how we plan ventilatory strategies, antibiotic policies, or whether interventions, which intervention, when to do. Similarly, one part of that is to plan the nutrition support of these patients. So this patient, when you need to start feeding, in this patient, we have seen that this patient is in shock. The initial resuscitation is the most important part. And these patients, as per the recent guidelines of 2016 ASPEN and the US ICM guidelines which has come up, most importantly, you have to stabilize the patient first and resuscitate the patient first and see that the patient is hemodynamically stable before initiating the feed. So initiation of feeding and resuscitation is important. Any patient who has got GIT bleed, see that there is a resolution of the gastrointestinal bleed which is there. And more importantly, if the patient is also into case of shock, whenever you want to initiate feeding on a patient on a high vasopressor therapy, you should initiate it only when there is a reduction in the dose of vasopressors and once the blood pressure has been stabilized and once they are reducing doses of vasopressors as per the guidelines. Especially if you feed in patients of shock, you will find that there is blood hypoperfusion giving rise to paralytic areas. There is also a risk of bacterial translocation which is going to occur. There could be non-occlusive bowel necrosis, and these patients can also have paralytic ileus, which can also be cumbersome. Now, important assessment, how much nutrition to give, you need to assess the nutrition state of the patient. So assessment of nutrition state, you need to start right from the time the patient is admitted into the intensive care unit. You should also take into consideration the basic history of the patient, the weight of the patient, whether the patient, how has been nutritionally before, whether he was eating adequately, and you must also judge when the patient is going to resume a full normal diet in the next few days or whether he is not going to regain full diet.
Pros and cons. Pros. The patient with anatomically and functionality, useful digestion system, always. Aids as support or complement in the patient with swallowing difficulties. Advance again. Anorexia, neoplasm, IEDs, dental malocclusion, esophageal stenosis, and patient with impressive. Nutritional requirements, sexy multitrauma burns, prevention of the multi-organ failure. In UCI renal failure. Patient with anatomically restricted digestive system by nasogastric tooth. Esophageal neoplasm, bowel syndrome by catheter. Complement stenosis of the zone section, difficulty in placing the catheter, prolonged maintenance post-operative undergo gastrointestinal surgery. Patient with of the functionality important digestive system nutrition in this above were the measure. Several liver failure cause the pancreatitis, malabsorption syndrome, neoplastic lower tract fistula, IEDs. Cont. Mechanical complication. All of them are related to the tip of the tooth and range from nasopharyngeal hair discomfort to erosion in the nasal mucosa or digestive tract and already more serious mechanical complication is the tractoesophageal fistula. The absolute complication to the use of the enteral nutrition is only determined by the presence of the intestinal obstruction, gastroduodenal perforation, acute gastrointestinal debriding, and abdominal injuries that require emergent surgery. Application in Ecuador. In critical patient back at the time of the admission and during their stay in the UCI, a follow-up and a summation of the health conditions of the carry-out nutritional. Unlike fasting where a situation of the hypometabolism occurs, the metabolic responsible to aggression, trauma, sepsis, both etc. Cause of neuroendocrine responses that produce hypermetabolism, proteolysis, insulin resistance with hyperglycemia, and loss of the functional fat mass. This complex metabolic responsibility can lead in a failed diet to the appearance of the proteins calorie malnutrition. It is recognized after the loss of underground neurons and that is produced from the 5-day with nutrients involved.
Welcome to Metabolism Matters. I'm Jennifer Woolley. Today we'll be taking a look at using indirect calorimetry to feed critically ill, morbidly obese patients. Let's take a look at a case. The case involves a female patient in her early 40s with sepsis after gastric bypass surgery for morbid obesity. The patient's nutrition parameters are as follows. Height is 5'3". Her actual body weight is 118 kilograms, which translates into a BMI of 46.1. And her ideal body weight is 52.3 kilograms. When this patient came in, she had a fever and she was hemodynamically unstable. And as I mentioned earlier, she had recently had a gastric bypass and had developed sepsis. To figure out her nutritional requirements, we first ran predictive equations, which gave us a range of 1,237 calories to 1,518 calories per day. Now, I hesitate to use predictive equations with this septic patient for two reasons. The first reason being that predictive equations are often unreliable during severe metabolic stress. And the second reason is that the patient's metabolism is likely changing frequently, which is typical when a patient is fighting an infection. Because indirect calorimetry allows you to pinpoint real metabolism more accurately than predictive equations, this patient is a great candidate for IC. To confirm that the patient's metabolism does indeed vary day to day, take a look at the numbers we obtained using indirect calorimetry data. On day 20, the patient needed 2,351 calories per day, and on day 23, she needed 1,966 calories per day. It's kind of cool to look at where we would have been with feeding this patient with predictive equations. If ideal body weight was used, we would have underfed. If we used actual body weight numbers, we would have overfed. And in a case like this, it truly is advantageous that we can measure caloric needs with indirect calorimetry. Well, that's it for today. I'm Jennifer Woolley for Metabolism Matters. See you next time.
Conclusion. Enteral feeding in critical ill patient is essential for the patient to recover and reduce morbidity and mortality. It is extremely important to start enteral feeding with 24 to 48 hours the admission to the UCI. Thank you.